Hello, everybody, and welcome to my YouTube channel, Nurse at Simplified. This is a channel, as its name says, it is a simplified way of managing our day to day nursing practices, our day to day nursing cases, and scenarios that come to us, and how we can effectively, promptly identify and manage them. So, in a way, this helps the nursing fraternity, be it nursing students or our grad nurses. In a way, it helps them to identify some cases because of some specific identification criteria which we discuss in our videos. So, don't forget to like and subscribe my channel and share it across the nursing fraternity. So, let's proceed today with one of the very important topic is pulmonary edema management. I got this request from a couple of my colleagues who wanted me to discuss how do we promptly manage pulmonary edema and how do you identify that, okay, this is a pulmonary edema. Let's not waste time. So today we will discuss about it one by one. The nursing strategies for effective treatment and care. In this video, I will talk to you about the pulmonary edema, its definition, causes, symptoms, and nursing management strategies. So, what is pulmonary edema? It is a condition characterized by excessive fluid in the lungs parenchyma caused by the extravasation of fluid from the pulmonary vasculature or the pulmonary vessels or the pulmonary capillary, whichever you call it, into the interstitium or interstitial space and alveoli of the lungs. Okay. Now we come to the what is the anatomy of the lungs. We all know the anatomy of the lungs. Why I want to stress on it before we start is so that we can connect to it instantly. So we have the lungs, we have the left and right bronchus, and the lobes are also present. The bronchial tubes are present. We can see the bronchioles, and that bronchioles it branches into alveoli. Alveoli, they are nothing but they are our air sacs. Next we come, as you can see in the picture, the bronchiole. This is your bronchiole. It branches into alveola, and we have the alveolar sacs. Okay. We have the healthy alveoli, which is filled with air, and we have the unhealthy alveoli, which due to whatever conditions, whatever background or whatever disease conditions has been filled with the fluid. Etiology. It is very important to know the etiology. That's when you can promptly identify what can be the causes. Now, there are two risk factors, or you can call them causes. One is cardiogenic or cardiac related volume overload pulmonary edema. The other one is non-cardiogenic. Why we call it cardiogenic is because there is a rapid elevation in the hydrostatic pressure of the pulmonary capillaries due to the reasons that we will discuss, and that leads to the overload. So first is the left ventricular systolic and diastolic dysfunction. Like in conditions like your acute myocarditis, like your non-ischemic cardiomyopathy and acute MI. These conditions, they do not help to effectively pumping function of your heart, and that leads to the difference in the capillary permeability and the difference in the hydrostatic pressure, and that leads to your pulmonary edema. The valvular dysfunctions, they are the mechanical causes like your atrial stenosis, atrial regurgitation, mitral stenosis, mitral regurgitation. There are arrhythmias like your AF with rapid ventricular response, ventricular tachycardia, or your blocks, especially the third degree or the AV blocks, your third degree AV block or complete block, whichever you call it. Now, what are your non-cardiogenic functions? Now, reason. Now, non-cardiogenic reasons why we call it, it can be due to either some lung injury, which has increased the pulmonary vascular permeability. And that leads to movement of proteins to the alveolar and the interstitial compartments from the capillaries. And that leads to hypoxemia and ARDS. So some causes are like your lung acute lung injury, smoking. There can be neurogenic causes, infections like your pneumonia, narcotic overdose like your opiate overdose, airway obstruction, and transfusion related complications. And so these are the cardiogenic and non-cardio. So why we were discussing about the etiology is because when the patient comes to you with a condition, for you to identify that it can be due to cardiac. So let's take a quick ECG, or it is because he had a chest trauma. So let's go for the next management. It will become easy for you. Pathophysiology. Now, when we talk about pathophysiology, I just want you to know a very small concept of what is a Starling force or a Starling equation. Why? Because though we learned it in our physics or in biophysics, why it is important is it is nothing but it is the rate of fluid filtration, how it is developed or how we get it by differences in the hydrostatic and oncotic pressure between the pulmonary capillaries and the interstitial space. Now, what I want you to understand or what I want you to know is what is a hydrostatic pressure and what is a oncotic pressure. For you to know what is oncotic pressure and hydrostatic pressure, it's very simple. Hydrostatic pressure or the work of hydrostatic pressure is to push the fluid out of the capillary. And what is the work of the oncotic pressure or oncotic capillary oncotic pressure? It pulls your fluid into the capillary. Okay, so it and your filtration rate is nothing but it is a fluid movement between the capillary and the interstitial space. Now what we want you to understand is like some conditions increase your capillary hydrostatic pressure, that leads to pulmonary edema. Some conditions they decrease your capillary oncotic pressure. That is, what will it do? What do you mean by decreasing a pulmonary oncotic pressure? It means that your fluids being pulled into the capillary is not happening properly. Okay, so the conditions are like, for example, in heart conditions like your congestive heart failure, the capillary hydrostatic pressure has increased. Whereas in liver diseases, your capillary oncotic pressure has decreased. In burn, your capillary permeability pressure has increased. In dehydration, your capillary hydrostatic pressure has decreased. So these conditions, it will eventually lead to fluid overload. So just for you to remember, just remember this much: hydrostatic pressure pushes, oncotic pressure pulls. This is just for you to know. Any change in this gradient will lead to increase in the pulmonary capillary pressure. Okay. So when we go to pathophysiology, it says that any etiological factors, like it can be cardiogenic, non-cardiogenic, whatever, it leads to imbalance in this Starling force or Starling equation, which leads to increase in the pulmonary capillary pressure, decrease in the plasma oncotic pressure, and it leads to increase in the negative interstitial pressure. So what happens eventually is that your capillary and your alveolar barrier is damaged. So it does not know what to do in what to be in the alveolar, what has to be in the capillary. They are all mismatched now. That leads to lymphatic obstruction, disruption of the endothelial barrier itself, and allowing the protein to escape. And that when protein escapes, it leads to movement of fluid between the tissues of the lungs, and there is accumulation of fluid leading to pulmonary edema. Now, what do you mean by staging? Staging, we have actually medically, when we go into details about pulmonary edema, you will know and you will hear there's something called stage 1, stage 2, stage 3. But for you, I want to just you to know the three basics: mild, moderate, and severe. What do you mean by mild? That there has only been some engorgement or some swelling of the pulmonary vasculature or the pulmonary capillary. Moderate means it has gone a step beyond and leading to extravasation or escape of this fluid into the interstitial space. Severe has that the pressure gradient in the interstitium and in the pulmonary capillary has changed. That has led to alveolar filling. Clinical manifestations. Why we say that clinical manifestations are very important, that is where nurses play an important role. So it's very important for you to identify the clinical manifestations and to filter it and say, okay, this is pulmonary edema, guys, we need to act. Now, as we always do, we identify it as symptoms that the patient comes with and signs that we see as a healthcare provider. So symptoms are acute and chronic. When we say acute, we mean that it is like SOB. We have a feeling of suffocating. The patient will tell, I'm feeling like anxious, cough and frothy sputum, diaphoresis, palpitation, chest pain. Chronic is like there'll be rapid weight gain because of the edema, paroxysmal nocturnal dyspnea, orthopnea, fatigue, ankle and lower leg swelling. Okay, so because of the edema. Signs that you will, as a healthcare provider, see is tachycardia because your whole system and your heart is trying to pump faster or pump efficiently to bring down this congestion that has happened. Tachypnea, confusion, hypertension, crackles. You can forget anything in pulmonary edema except for this one sign, that is crackles, which only you can identify. That is of auscultation of chest sound. Jugular vein distension, hypoxia, bilateral lower limb edema. So when a patient comes to you as a quick snap, what will you see in the patient? He is running to you, or the family has brought to you this patient saying that, ma'am, this patient has shortness of breath. Okay, so you will initially give him comfortable position, give him a high Fowler position, and oxygen support after seeing the oxygen saturation. Hook him to monitor. The next thing is auscultate his chest, his lungs. You will find crackles or rails. Any of them identifies that this is a sign of pulmonary overload or congestion or fluid. So this can be one of the reasons for pulmonary edema. How will you confirm? You have other diagnostic tests, but before that you can also assess for quick assessment of the lower limbs to see for edema. Now, as I said, we have something called the diagnostic criteria. First is, as it goes without saying, you can by heart it or you can do anything you want to remember, but you must remember that if you see a patient with shortness of breath, dyspnea, crackles, cough with a pink frothy sputum, chest pain, tachypnea, palpitation, rapid and shallow breathing, anxiety, hypoxemia, confusion, cyanosis, though it is a last sign, it will be a great diagnostic evaluation of pulmonary edema. Next, we come to chest X-ray. It will show some clinical or some classic features like cardiomegaly, enlarged heart shadow, cephalization, that is there will be some vascular prominence in the upper lobe. We have something called, which is new and it's quite uncommonly used now, that is a curly B signs lines. They are the horizontal lines you will be able to see towards the lung base, that is somewhere here. You can see some horizontal lines here. Next is a battering infiltrate. What are they? They are a blunting of the costophrenic angles. Central alveoli opacities that you will see. Alveoli opacities that you can see here. This is battering pattern and vesicular pattern, that is interstitial fluid thickening. ECG is done to rule out cardiogenic causes like AF or MI. And echocardiography to see how well your ventricles are functioning or how well the ejection fraction is happening. And then we have something called the pulmonary artery catheterization. It is the golden standard, my dear friends, for diagnosing pulmonary edema, though it is invasive and thereby it is less used. But this is the golden standard. It is nothing but is a procedure where they insert a swan gaze catheter, that's a flexible balloon tip catheter, into the large vein. It can be a subclavian or an internal jugular through the through the right side of the heart and then into the pulmonary artery. So why are we doing it? We are doing it to see your heart function, the fluid status, my dear friends, measuring hemodynamic parameters, and it will help you because already you are into it, like for patients who are having like shock or heart failure. And what are we trying to measure? We are trying to measure the CVP, central venous pressure, the right arterial pressure. We are trying to see the cardiac output and the systemic vascular resistance. Okay, and when we are trying to do it, we have certain complications, but then they are even today some physicians do use them. Okay, and once it is done, we can confirm that yes, this is a case of pulmonary edema. Next, we come to something called the medical management of pulmonary edema. What do you mean by medical management? This is a mnemonic that is used from long time among nurses, among medical professionals. For us, it is like a by heart thing that is called mad dog. Morphine, aminophylline, and digitalis, diuretics, oxygen administration, and gases or ABG. Now, when we say morphine, why it is a very classic method actually. This in critical care we used to use before. Morphine, why we use? Because it helps in vasodilation and thereby reduces your pulmonary pressure, and it reduces your sympathetic nervous system activity basically. So it relieves your chest pain and your anxiety. Next is aminophylline. Aminophylline, to be very honest, now I don't see it much common in use. We used to use it before. Like it's a bronchodilator, which helps to relieve your bronchospasm, and it improves the ventilation. So it has, and it also has a mild diuretic effect. Digitalis, that is digoxin, we use it quite often. That is, it increases your cardiac contractility at the same time supporting your right ventricular function, which may be due to your right-sided heart failure. And we have diuretics, that goes without saying that it is used in all the settings. Mostly it is to reduce your preload because it is a loop diuretic and it manages your pulmonary congestion. So but one thing we need to see is of course hypertension. Oxygen support, because it corrects your hypoxemia, and we can give it by mask and cannula depending upon the respiratory status of the patient. But if you have a patient with ARDS and he comes in with hypoxemia, do not wait, intubate. And G stands for your ABGs, and or it even stands for anticoagulation, which is a cornerstone of pulmonary edema treatment. It prevents further clot formation. Okay, so these are your mnemonic for your management of pulmonary edema. Basically what we try to do is we try to prevent further deterioration. Surgical management I have not included in this because surgical management depends upon what condition, what is the differential diagnosis of the patient. That's why I have not included this as an important, as a chapter in its, as a different explanation in itself. For example, you have a patient coming with a condition which is quite natural. You know that it is due to cardiogenic cause. So in that case, you have identified it to be MI. In that case, you have a surgical management here. You have CABG. You have the patient going for a PCI. So that's why it is depending upon the disease condition that you are in, or the disease condition that the patient comes with. And similarly, some other condition like if he has some valvular dysfunction, in that case also it can be due to some mitral regurgitation or some mitral stenosis or something like that. In that case, you will also have surgical management there. So basically surgical management, why we are more focusing, not much focusing on the surgical management, is we are trying to address it as an emergency. As I told you, it's a condition, so we are trying to identify the condition and medically manage it till the surgical treatment or decision is made. Nursing initial assessment of patient with pulmonary edema. The initial assessment should focus on your A, B, C, D, E, as I always recommend: airway, breathing, circulation, disability, and extremity. So, airway you have to manage. Severity of respiratory distress, depending upon the severity of the respiratory distress, you may have to intubate the patient. Continue your monitoring of the vital signs, pulse oximetry, and laboratory values. Why we say initial assessment? Because that gives you a baseline and thereby saves your patient. So, in a nutshell, what do you do when a patient comes to you with PE? Initially, it is initial assessment, as we discussed. Quickly identify the few points when the patient comes to you. He's coming to you in distress, respiratory distress. Give him a comfortable position, high Fowler's position, support him with oxygen, and do an ECG. In the meantime, auscultate the lungs for presence of crackles, go through the lower limbs to see if there is edema, and call the physician as early as possible so that you don't waste time in identifying. So positioning, monitoring, medications, and then when the physician is on board already, he has the ECG in front of you. He knows, he has a baseline about the vital signs. He has a baseline about the lung auscultation. He has something related to the history. So this will help to save time. Then we start with the diuretics, vasodilators, and morphine. It must be given very carefully and cautiously, and oxygen therapy to maintain the adequate oxygenation. If ARDS, support in mechanical ventilation. Patient education and counseling of patient with PEEP. That is, you have to teach them about the importance of adhering to fluid restrictions, which means that the patient is not in a condition to know why this happened. So tell her or him that this is your baseline. You have a condition called liver cirrhosis. You have a condition called, like chronic kidney disease. So these are your reasons why your fluid is building up. So you have to adhere to the fluid restrictions. Dietary modifications for your cardiovascular risk patients, prescribed medications, emotional support and counseling may also be necessary. Complications. One is your acute respiratory distress. Goes without saying that it is characterized by severe hypoxemia where and you have respiratory failure as well. So when it is respiratory failure, it goes to say without doubt that the patient should be given mechanical ventilation through intubation. Early recognition and intervention is essential to prevent deterioration. Cardiovascular implications are patients with pulmonary edema, they are at a risk for cardiovascular complications always, such as any sort of arrhythmia like your AF, MI. So maintaining a stable hemodynamic and monitoring for the vital signs and cardiac parameters are very important. Psychosocial support says that chronic respiratory conditions like pulmonary edema can lead to significant psychosocial effect, which includes anxiety and depression. So, nurses should assess their mental health, provide support. It can be through psychological support or with the help of social support groups or with the help of mental health professionals. One thing that I want each one of you to know that nursing management of pulmonary edema is the pivotal. Why? Because we assess, they come to us first. We are the first line of contact. So they come to us. So a thorough assessment is very important. That will help the team to identify the prompt intervention, followed by patient education. If you understand the potential complications, we can give a comprehensive care. Thank you so much, each one of you, for attending and for listening to the topic of pulmonary edema. Why this has brought or this has been of importance is many times we wait when a patient comes with SOB, we just give them oxygen and we wait for the physician to come. Maybe he's already seeing another critical patient on the other hand. You can do some quick checks or you can do some quick steps before he arrives. What are they? Giving him a comfortable position, supporting him with oxygen, checking his vital signs, attaching him to a monitor, doing a quick ECG, and another nurse can check his or auscultate his lungs to check for crackles or rales. And if it's advanced, you will notice it will be wheezing. But initially, he will come to you with crackles. Then making a quick check assessment to see for if he has some additional medical history or some cardiovascular risk factors and also his lower limb for edema. So before the patient comes to you in a 5 to 8 minutes, he has some baseline data already to intervene. So we didn't lose time. So that's very important for each one of you to know. Thank you so much for attending my session. And in the following videos, we will discuss more critical topics, and if you have anything that you want me to talk about and discuss, we are most welcome to do so. So keep watching. Do like, subscribe, and share the information and the channel views so that each one can benefit from the information given. and we can quickly save the life of the patients. Thank you so much. Bye bye. Take care.